I'd like to welcome you to our very first DAMA Expert series. You may have noticed that we didn't actually use the word series in the first invitation. That's because you can't really call something a series if it only happens once. But since more than 90 people actually signed up for the webinar, we thought, all right, let's make it a series and make it happen. It's worth doing again. So we'll put a poll during the whole presentation. That I'll show right after. So we've put a poll that you can answer if you want to share with us more information about the next webinars and what subject you might be interested in. There will be also a link at the end of the presentation. This is our first time hosting a webinar, so we're particularly proud to introduce our speakers, Professor Mariano SUPPA from Hospital Erasme in Brussels, Professor Julia WELZEL from Universitätsklinikum Augsburg, and Professor Thomas DIRSCHKA from CentroDerm in Wuppertal. So thank you for presenting. That being said, none of them really needs an introduction, I think. You know them already. So today, as you saw, we focus on BCC because this is where it all started with LC-OCT. As you know, DAMA Medical is still a small company, but despite Deep Live receiving its CE marking only about 3 years ago, there are already more than 120 systems installed worldwide, both in major hospitals and private practices. Before we jump in, just a couple of housekeeping notes. You may see that you cannot activate your microphones and cameras. This is because it's a webinar, but you can, of course, and you are invited to ask questions in the Q&A section. So feel free to do that, and we'll bring the questions to the attention of the speakers. The session is also being recorded to be able to share it and see it afterwards. All right, let's get started. Professor SUPPA, the floor is yours.
Thank you, and good evening, everyone. Let me see if I have control. Yes. So today it is my great pleasure to participate and to open this first episode of LC-OCT Expert series. And today we will be speaking about AI-assisted LC-OCT for BCC Diagnosis. You might know that very recently we published an important study about this, and today I will have the pleasure to talk about this to you. Okay, so those are my conflicts of interest. In particular, I had the privilege to have a free of charge prototype of LC-OCT in my department in Brussels for a number of years now, with which I perform clinical research. And this is my only conflict of interest with DAMA. Everybody knows that LC-OCT stands for Line Field Confocal Optical Coherence Tomography. We know that this fantastic device is able to combine the principle and the technical advantages of conventional OCT on the one hand and reflectance confocal microscopy on the other hand, and all this with line illumination and detection. What does it mean to combine the technical advantages of OCT and confocal? It means to be able for the device to have at the same time high resolution comparable to the one of confocal microscopy and high penetration comparable to the one of conventional OCT, although half in the penetration, 500 micron. The device is able to provide vertical imaging in a fashion that is similar to histopathology, and at the same time horizontal imaging in a fashion that is comparable to confocal microscopy. Then, of course, we are able to recombine vertical and horizontal imaging to have a three-dimensional reconstruction of the skin. Then the device has integrated dermoscopy, meaning that there is a dermoscopic line integrated in the same probe of the LC-OCT, and this integrated dermoscopy recently was made available for colocalization on a bigger dermoscopic picture, which is paramount to perform complicated, what used to be complicated acts, such as the margin pre-surgical delimitation. And then, of course, more recently, artificial intelligence was added to the device, and that's why we are here tonight. So, all this device, as you know, is commercialized by DAMA Medical under the name of Deep Live. And now there is artificial intelligence for basal cell carcinoma integrated in the machine, and it is CE marked since May 2024. So this is a basal cell carcinoma, and if you switch the artificial intelligence on the device is able to tell you, yes, this is a basal cell carcinoma with 100% of probability, and you see that the image gets colored in yellow when the device is able to see a BCC lobule, and it colors the part of the image where you can see the BCC color. This is called heat map, and this is great to teach even the non-expert observer of LC-OCT where the machine is looking in order for it to be able to say, yes, this is a BCC. So this is a great feature, not just because it tells you with the probability score that this is a BCC, but also because it teaches you where the machine looks at to be able to say, yes, this is a BCC. And in this particular case, this was a superficial BCC because you see that the lobule is connected to the epidermis. I'm trying to change. Okay, sorry, I'll go back. Okay, so this is, sorry, there is a little technical problem. Okay, fine. Now, okay, this is another image of another lesion, which is not a BCC. And you can actually know it, of course, if you know the criteria for BCC under LC-OCT. But even if you don't, and you switch on artificial intelligence, you see that artificial intelligence tells you, no, this has 0% probability to be BCC, and so you can be reassured of your negative diagnosis. In particular, this was a dermal nevus because you see a particular pattern in the dermis, which is called wave pattern, because it resembles the waves of the sea here. The algorithm of artificial intelligence for BCC was developed by Damae Medical based on more than 600,000 images collected from over 1,000 patients and over 1,100 lesions. Of course, all of them histopathologically confirmed. Around half of them were basal cell carcinoma, and around half of them were not basal cell carcinoma, but basal cell carcinoma imitators. The images were collected from 5 European hospitals based in France, Belgium, Spain, Italy, and Germany, and it was really a real-life consecutive data set in which, apart from basal cell carcinoma, over 20 differential benign and malignant differential diagnoses were included. All this gave rise to a big European study, which we recently published on GADV. This included 43 European dermatologists that you can see all listed here. In this study, the performance of clinical endermoscopy alone, LC-OCT without artificial intelligence, and LC-OCT with artificial intelligence were compared in experts with different levels of expertise in LC-OCT. The study, as I said, was multicentric, and it showed very interesting results. So I told you already that it was performed over 200 equivocal lesions by 43 dermatologists. The study design, very briefly, was simple. Basically, the participating dermatologists were asked to diagnose half of the lesions using LC-OCT alone, and half of the lesions using LC-OCT with the addition of artificial intelligence. Then, after a washout period of at least 2 weeks, ensuring that the observers could not remember the diagnosis that they made. After this washout period, they were asked to reperform the same diagnosis, but inverse. So the lesions for which they used artificial intelligence in the second round were diagnosed only with LC-OCT and vice versa. The primary objective of the study was, of course, to compare the diagnostic accuracy of traditional methods with methods based on artificial intelligence. This is what we found. This is a complicated image but a very interesting one because it shows a very important concept. And if you look at this, you can see that the observers that were novice or intermediate users, with the addition of artificial intelligence, reach the level of experts. This is better explained in these images. So you see novice observer, clinic and dermoscopy alone, 70% of diagnostic accuracy. When they use LC-OCT, they go up to 83%. But with the addition of artificial intelligence, they obtain 91.4%. This is comparable to the diagnostic performance of expert users of LC-OCT without the use of artificial intelligence. It is important to note that in this study, the expert level was defined as at least 2 years of experience with LC-OCT. So basically, what does it mean? It means that even non-expert observers can obtain basically the same diagnostic performance of experts when they use artificial intelligence. And so basically it means that artificial intelligence erases 2 years of need of performance gain with LC-OCT. So basically you save 2 years of time, which is a great result. An example, so this is a lesion under clinical endermoscopy examination. Just on a clinic endermoscopic ground, in round 1, 79% of participants, and in round 2, 72% of participants got a correct answer. With LC-OCT without artificial intelligence, only, sorry, technical problems, only 70% of participants got a correct answer. But with the addition of artificial intelligence, this percentage rose to 98%. I'm sorry about this, but there is a technical problem. So basically, this was an example to tell you that here you can see a superficial BCC, here, highlighted by the artificial intelligence. This is quite subtle, so of course it could be seen in the same image without artificial intelligence, but only 74% of participants or participating dermatologists were able to spot it, whereas with artificial intelligence, 98% of participants were able to correctly diagnose it. Another example, a lesion on the clavicula. 60% of participants got the right answer based on clinical endermoscopic examination. When performing LC-OCT, here we see, without artificial intelligence, here we see a big lobule in the dermis. And only 54% of participants got the correct answer. By the way, the correct answer is not BCC in this case, but it is sebaceous hyperplasia, because you see granules on the top of the lobule and loss of signal at the bottom of the lobule, which is pathognomonic of sebaceous hyperplasia. But it is a difficult diagnosis if you're not an expert observer. With the addition of artificial intelligence, here you see that the artificial intelligence tells you, yeah, this is a BCC with 0% chance. So this is not a BCC, and it is actually a sebaceous hyperplasia. And indeed, the percentage of correct answers rose to 77%. So by almost 20%. So the impact of artificial intelligence in my clinical practice is significant, even though I consider myself to be an expert observer of LC-OCT because I've been using it since end of 2018. But I still use artificial intelligence because I get more accurate diagnosis, a better evaluation of the prognosis because I'm more able to do a subtyping of BCC. I'm also able to monitor in a more effective way the efficacy of non-invasive treatments. And I'm able, with much more ease, to determine the pre-surgical margins of BCC, and you will see this later in the later presentations. Also, I'm able to get a faster and better management of multi-lesion patients, which I get more and more. Sometimes I get patients that have 15, 20, 30 suspected lesions, and with the help of artificial intelligence, I'm able to perform a lot of examination in a faster time. For example, This patient came recently to my clinic with 13 lesions, all of them suspected of BCC. So without LC-OCT, of course, I would have performed 13 biopsies, which is not ideal. Of course, I did instead 13 LC-OCTs. What is interesting to note is that I did my first exam at 13 past 2 p.m. and I finished my 13th exam at 26 past 2, meaning that I did 13 suspected lesions in 13 minutes with an average of 1 minute per lesion. And this was because with the help of artificial intelligence, I could go really fast. And indeed, here you can see on the summary that the machine provides with the colors of artificial intelligence, only the BCCs are colored in yellow, and you can immediately spot that we have, out of 13 lesions, 7 BCCs and 6 non-BCCs. So I think that we have to take home a few messages. Of course, LC-OCT is a great device. We all know that. That's why we are here. And this is because it combines the advantages of confocal microscopy and OCT with integrated and co-localized dermoscopy with a high level of similarity with histopathology. Now, of course, we have the integration of artificial intelligence for BCC. More algorithms of artificial intelligence will soon come. And I think that LC-OCT has an important clinical role for basal cell carcinoma, of course for the diagnosis and the prognosis, but also for the monitoring or treatment, and as we will see just now, with the delimitation of surgical margins. Thank you, and I would like to also to acknowledge my team in Brussels. Thank you very much.
Thank you, Mariano. I'll hand over the control and the floor to Professor Welzel, who will talk a little bit more about the use of LC-OCT for margin assessment. So, Professor Welzel, you should have the control now.
Hello to everybody. As Mariano already mentioned, so we now have a fantastic tool for diagnosing BCCs. And the question is, for what topics should we use it in the clinical routine? And so everybody who is dealing with BCCs is knowing that the question of pre-surgical margin assessment is a big question for most surgeons. So that and normally we do it without any imaging. We do it just by a dermoscopy to mark the margins of a BCC. But now if we have this fantastic tool, so we started to use it for pre-surgical margin assessment. So Mariano already demonstrated that if you use AI to assist you with the diagnosis, it's very easy to see where the BCC is. And so the next slide. And he already mentioned the multi-center study, and we also participated. And so our experience is that as an expert, we don't need the AI on top, but it is still very helpful because it increases your velocity in imaging. And this is important if you have to scan large areas or multiple lesions. And also, if you have young fellows with not so big experience, then it's also very helpful because your learning curve is much faster. So on this, you already demonstrated the result that you save some years of experience. So, and what is also very helpful that our machine has a so-called co-localization of dermoscopy and LC-OCT. This is very important if you start to scan the margins, because otherwise, or before we had this nice add-on, the nice dermoscopy, we did it with the line field confocal, but it was not so easy to locate where you exactly do the measurements. And as you see here, at first you take the overview with dermoscopy, and then with the LC-OCT you are navigating inside the margin, or just exactly at the margin, and you always know exactly where you are, because this is co-located with the dermoscopy image you see here in the lower right border. And this makes it very easy to scan the margins of a BCC before you do surgery. So here another example. So when we at first start with the overview dermoscopy device and then scan over the area, and it is exactly marked where you are, and it's also automatically marked in yellow where the system is thinking where the BCC is, as you see here. And then it is really easy, so you don't have to look onto the screen. If you see several images at the margin and all are yellow, then you are nearly 100% sure that there is still some BCC in the margin and you have to enlarge the margin before doing surgery. So we did a multi-center non-interventional study with the device, saying that the surgeon is marking the margin using dermoscopy, and then the patient is sent to the imaging room, and we did imaging and control the margin. But if we saw some BCCs, then we don't change the margin, so that we really have a one-to-one comparison to histology. So that this was not so easy for us, because when we see clearly some BCC in the margin, we would like to say the surgeon, okay, he should enlarge it. But for the design of the study, it was really much better to confirm if it's exactly correlating to histology. And for that study, we also used an ex vivo design of the probe, where we put the freshly excised tissue just on a special plane. And we imaged not the skin inside the patient, but the ex vivo tissue to look for the lower border of the piece of tissue. Because if you know that the line field confocal, the penetration depth is limited, then you only can say something onto the lateral margin of the tissue, but not on the lower margin. And therefore, we combined this study with the ex vivo setting. And we included 43 patients with a total number of 50 lesions in different areas and also different subtypes. So just in a prospective way. And we divided the whole tissue into 4 quarters, like in histology. If we make really a 3-dimensional margin reconstruction, we normally make the so-called Tübinger Torte in histology, or the Munich technique, where we make horizontal sections of the tissue. But nevertheless, we did a complete 3-dimensional reconstruction with histology, and we compared this with the line field confocal results. And these are our results. So we really find nearly 100% correlation to histology, and only very single cases where there was not a correlation. So that, for example, we found some parts in histology in the margin and not in line field confocal. And also vice versa. We had only a very few cases where it looks in line field confocal positive, but we didn't find it in histology. And we followed up those cases by looking exactly into the histology, for example, doing more sections. And in not all cases, but in most of the cases, line field confocal was correct. Because we really, if these were very small pieces of basal cell carcinoma, we had in some examples, we didn't find it exactly in histology, only if you make further cuts, for example. And so we are now starting a prospective interventional study with several centers in Germany, where we do it in the right way, that if we see something clear in line field confocal, then we will enlarge the margin, and hopefully we only get it into one single stage out and not need further re-excisions to get the whole lesion cut out. This is another example for a positive margin, again with artificial intelligence, and it's completely clear that there is a BCC on the margin, and you can really exactly locate it here, for example, and an example of a negative margin where the line is always staying in blue color and no yellow spots in between. And this is rather fast. It, of course, depends on the diameter of the lesion, of the size of the BCC, of course. And if it's a very large BCC, then you have to make several single movies because the length of the whole video is otherwise too long, but it takes about some minutes to get it. And if you compare this time you invest into the patient, comparing to a re-excision of a patient where you have to go again to the surgical room and make a next local anesthesia and so on. So this is very cost effective and also very sparing of resources if you do it before surgery, the exact margin definition. And it's also now integrated into our clinical routine. This is a small example. We got this video from a colleague in France, but we do it exactly in the same way now in daily routine. And as I already mentioned, it's very fast and easy to perform. And then you can really have a high percentage of basal cell carcinomas excised within one single step of surgery. As you see here, the margin is enlarged when the margin is positive in that way. And so it's tissue sparing, but also really a fast procedure for most surgery and a very safe procedure. And we also use it not only for cases before surgery, but also for aftercare. This is a nice example of a patient where we got the result of the histology after most surgery, after closure of the wound. And so you see here the scar, and we know that there is still some BCC inside. And the patient said to us, no, I don't want a next surgery. So the scar is looking nice. I don't believe that there is some BCC in. And of course, you can do dermoscopy. Here you see the scar, here the center of the scar. And you can do it with the line field confocal, the overview. So it's completely unsuspicious with dermoscopy. But if you look with the line field confocal, then you clearly see a very small part of BCC left. And if you show it to the patient, then the patient, of course, will say, okay, I will do surgery, or I will undergo surgery. And then you only have to cut a very small piece where the BCC is. And this is very easy and fast. And in many cases, so we don't find parts of the BCC, even if we have a positive histology, because during wound healing, there may be some BCC parts are going away and so on. And for the German-speaking participants, I would like to switch to German. So wir werden einen Workshop haben auf der nächsten Cobra in Leipzig. Und wer noch nicht so sehr viele Erfahrung hat in Line Field Confocal, da kann man das tatsächlich sehr gut praktizieren. Also ich mache da ein bisschen Werbung für diesen Workshop. Und was vielleicht noch wichtig ist, wer Lust hat, an dieser Studie teilzunehmen, die wir in Deutschland jetzt starten, kann direkt nach diesem Kurs zu einem ersten Studienmeeting kommen und dann auch überlegen, ob man sich als Zentrum mit registrieren lässt. Je mehr, desto besser. Also wer Interesse hat, so who is interesting, please participate in this interesting workshop for beginners and also in our multi-center study. And thanks for your attendance and attention. And so I must say that most of our work is done by our really nice colleagues and not only by me in Augsburg and also in Munich and all our other collaboration centers. Also, like I would thank to Mariano. So we are working really brilliant together. And I'm open for questions if there are some.
So thank you very much, Professor WELZEL. We'll keep the questions for the end. I already see that we have 2 questions in the chat. So I see them, and we'll make sure to take them right at the end of the presentation. And just before that, I'll give the floor to Professor DIRSCHKA, who will present a few the integration of LC-OCT into clinical routine. Professor DIRSCHKA, you should have the floor. You have the floor, and you should have the control of the presentation right now.
Yeah, thank you very much. Welcome, everybody. First of all, I'm very happy that I can be part of this scientific group. I'm an office-based dermatology, so I view it more through the glasses of an office-based practitioner. So I'm not a university guy. And for me, in my office, it's very important that everything works very precisely and works very quickly, and that everybody who uses the devices that we do have is very happy with the devices. Because if people working with the device are not happy, they won't use it anymore and they will be frustrated. And I can tell you that LC-OCT is the first device that I do not want to renounce anytime because it's very useful. It's of great practical value. It's of great value for our patients that we investigate before surgery, for instance. And I think there are numerous applications that can be directly integrated into the workflow of a dermatological office right away. So it's not merely, sorry to say, Julia and Mariano, not only a scientific device to answer some, because we have seen many scientific devices that can answer scientific questions, and we are very happy to have solutions, but it takes like many, many minutes or even hours to obtain some photographs. No, this is a practical, and this basis, of course, on your work, a practical device that can be practically used for the sake of our patients. And what I want to show you today is how we use it for BCC. And I think this will be a revolutionary device because it will change the way we treat BCCs, because our old style micrographic surgery or old style Mohs surgery will be at stake if we use LC-OCT. So these are my conflicts of interest. Of course, I do have a conflict of interest with DAME because they have given me the device to use it liberally for a couple of months, but meanwhile, I pay. I'm not happy with that, but it's worthwhile. Some cases from our office, you have seen this vivid page images. I have some images without and with AI diagnosis, but I think it's very easy if you get used to these images to diagnose those specific parts of the image by yourself. You see what they called a feuille sign, which means 1,000 leaves are stapled somehow in without any order, and you can see there's like drizzling of snow inside those lesions. And if you look at the heat maps, the artificial intelligence recognizes this pattern, and this is also the case here. Sometimes you see a little rimming surrounding the nest of the basal cell carcinoma. This is I believe is mucin, because all the basal cell carcinoma nests are histologically surrounded by a little rim of mucin, and I think this mucin can be detected by LC-OCT. And look here, LC-OCT recognizes it perfectly. And here again, other examples of a basal cell carcinoma and also precisely detected. Now, how do we use it? This is a realistic example from our office, a lady with a little spot on the tip of her nose. And I think it's even hard to tell what this might be. Even dermoscopy is not the right clue for that. You see some vessels, you see some hyperkeratosis, but it's hard to tell what it might be. So first thing that we did, we investigated with LC-OCT, and you see it's a clear basal cell carcinoma, without doubt basal cell carcinoma. So this is the first advantage. We can substantiate our diagnosis, and these 100% are 100% specificity and sensitivity are very high with LC-OCT. And then we start investigating our patient. You see this lady. She consented showing her images for educational purposes. She's complaining about this little lesion. We take a little drop of oil, and then we use this device. With 2 hands, we try to focus the tip of the device between two fingers, and you see very easily, we see here our navigation throughout the lesion, and here we see the basal cell carcinoma. So this is a clear diagnosis, but this is only the first step. Second step should be to excise this basal cell carcinoma as precisely as possible, so not wasting too much tissue and not running into the situation, not excising this tumor in total. So here you see our diagnosis, and usually, this is what we usually do. We have this basal cell carcinoma, we excise with a little safety margin. We put some sutures on top so that the histopathologist knows clockwise about the orientation. Then this will be worked up in the histopathology lab. We take a look under the mic, and if the margins are not free, we continue our process, as in this case, many, many times. So this is our standard procedure. But with LC-OCT, we can definitely improve, and for sake of time, also improve this procedure. So what we do, and this is our practical approach, we mark and precisely delineate the lesion. Precise delineation of the lesion. This is the delineation of what we see, what we assume this might be the lesion. Then we take a second circle, like 1 millimeter apart, and then we investigate the zone exactly in between by LC-OCT. And believe it or not, every clinical assistant in my clinic can do this because it's very easy. It requires like 10 minutes to explain how this procedure works, which is very important in my clinic because I've like 11 people working with me, always new people working with me, and it requires really only minutes to show how this machine works. Of course, it requires years, and Mariano, you've mentioned this, to become a super expert. With assistance of AI, even nuts can perform the image and find the proper thing if you know what you're looking at. So this is our second cycle. Then we do our final adjustment and have a third cycle, and this is our final basal cell carcinoma. This is where we will do the excision. So then we excise, and what I will show you now is off-label. This is definitely off-label because, Julia, we do not have this nice in vivo device that you have in your office where we can directly look at it, but we use the LC-OCT to directly look at the excised specimen, and you can see that we can localize the basal cell carcinoma in the very center of the lesion, and then we go to the edges of the lesion and we can try and figure out if the edges of the lesion are really free. So this is what we are doing. Thank you for your kind attention. If you would like to improve your surgical procedures, I think there's no way in omitting LC-OCT in the future, because for basal cell carcinomas, this is, to my mind, the very future of dermatology. Thank you very much for your kind attention.
Thank you very much, Professor DIRSCHKA. Yeah, so we'll get on with the questions. I see that we have a few in the assistance. So you should still be on yeah, great. I see everything. I see one question on the QR code in the end. Are you talking about the QR code that was in Professor WELZEL's presentation, I guess? So I'll show I'll go back to that part. Sorry. And I'll take the other question at the same time. There it is. So I see one question about were the lesions easy to diagnose with clinical image and dermoscopy in the study? I'm not sure to whom this question was addressed. I guess it was addressed to Mariano. So
I think
Mariano,
so because yeah, I showed the results of the study. Well,
yeah.
not that easy because we saw in the performances of the study that actually LC-OCT with artificial intelligence enabled an improvement of the diagnostic performance compared to clinic and dermoscopy alone by 20%, which is a lot. And in this study, a third of the dermatologists were experts also in dermoscopy. So, and actually, more or less everyone was expert in dermoscopy because the level of expertise were regarding the LC-OCT expertise. So they were not that easy to diagnose.
Thank you,
So
Mariano.
basically, I would say novices got around 70% of diagnostic accuracy on clinical dermoscopy, and experts got more or less 75%, 76 to 79% by memory.
All right. Feel free to ask more questions on that subject if you think you have more questions on that. I see another one saying that I am in a private practice. Is it easy to use the AI, and how long is the training? I guess the question could be more either to Professor WELZEL or Professor DIRSCHKA, who wants to take it.
Yeah, so I can answer. It's
Thank
very
you.
easy because you only have to switch it on. And then it's displayed onto the screen. And I would recommend if you are a beginner, then you should at first try to train your brain with pattern recognition, that you try to see the BCC by yourself to detect it, and then switch on the AI. But it is very easy to use it because it's integrated and you could also do it afterwards. So you only switch it on and then you see it during your measurement. And I would nevertheless recommend that you at first try to train your brain, that you also can recognize it without AI. But if you are used with AI, it makes it much easier and faster.
Yes,
Thank you very much.
I can fully agree because I'm in office and every new part of my members take like half an hour of training and then they can first time use it directly. It's very intuitive and it does not require much explanation.
I have another question on melanocytic lesions. Someone asking if we can use LC-OCT for melanocytic lesions. Maybe
So I
my
can also answer it,
go on.
or are we both, Mariano?
Yeah,
So
yeah.
of course we are using it for several other things. For example, in melanocytic lesions, it's also working perfectly. It's comparable to confocal microscopy because the resolution is the same. And for confocal, there are numerous studies, meaning that you really can differentiate between dysplastic nevi and melanomas and so on. And especially if you have a melanocytic lesion in children or in regions where it's not so useful to make a biopsy, perhaps, for example, at the upper eyelid, then it's really very helpful to have a short imaging with LC-OCT to recognize the patterns. And so for melanocytic lesion, the AI is at the moment not CE marked, but it's on the way to be trained. And this would be also very nice if you have it with AI. But if we know the features from confocal, for example, we can apply them one-to-one to line field confocal because the resolution is similar.
Yeah.
And it's very helpful if you also have it in 3D, because then you have the vertical and the horizontal section of a melanocytic lesion. So I love it also for melanocytic lesions. We also take it for diagnosing of onychomycosis. This is also published, or for scarring and non-scarring alopecia. Several indications where you can use it.
Inflammatory diseases,
Inflammatory
there
diseases.
are evidences now. It's really nice. I completely agree with you, Julia. And yeah, I mean, what I really like about LC-OCT for melanocytic lesions is that you really have this information about the architecture of the lesion, which was more difficult to get with confocal because confocal is only horizontal. So you really need to have a three-dimensional brain to imagine what's happening in the architecture. Whereas with LC-OCT, you also have the vertical component and you can combine it with the horizontal component. And this is a very important information to me for melanocytic lesions, which is great to have. And I also agree with when artificial intelligence will arrive also for melanocytic lesions, in my personal view, it will be a game changer. Absolutely.
Thank you, Mariano, and thank you, Professor Welzel. We also have a question on is AI-assisted LC-OCT also precise in locating the infiltrative type of BCC?
Shall I
So I
take
don't
it?
know. Yeah,
Yeah,
go on.
of course, yes. LC-OCT for BCC is very precise and you can see everything, provided that what needs to be seen is above the limit of 500 micron, because of course you cannot see underneath. Uh, the question remains how many BCCs, how many infiltrative BCCs uh, can be deeper than 500 micron, a lot of them, of course, but how many don't have nothing between 0 and 500? In my experience, very, very few. So this is a study that we need to perform by joining forces. I think Thomas and Julia, I think you agree. So the worst that can happen in my clinical experience is that maybe in a few cases you can skip a very deep infiltrative component, but still you excise the lesion because you see something between 0 and 500. So it's I only very rarely missed an infiltrative BCC due to a component of the tumor which was too deep because something was happening also above 500 microns. I don't know what is your experience, Julia, Thomas.
I think
I
sometimes
agree completely.
I think sometimes it can be difficult if, for instance, uh, this is what we see in office-based dermatology. Somebody has performed a curettage, for instance,
Yeah,
and
yeah.
thrown away the excised material. And it was all of a sudden it was like an infiltrative basal cell carcinoma, and on top a big scar occurs. And now the question comes, what is beneath this scar? Then it can be critical. And for those cases, I would perform a little excision biopsy. But this is only a very limited number. I think the opposite is right. For instance, you excise a basal cell carcinoma in a like 90-year-old patient, and the patient does not want a second excision because it has not free margins. So then we can precisely measure the infiltration depth at the lateral part of the lesion. And often we have such a low infiltration depth that non-invasive procedures like PDT, for instance, or 5FU can be used. I think this would be a very nice application. And I always ask my histopathologist to measure the infiltration depth of a basal cell carcinoma at the lateral margin because we want to know what is there, how deep does it go, and is there a possibility, a chance for a non-invasive a treatment option. This could also be done and performed with LC-OCT, of course.
Absolutely.
Thank you very much. This is maybe the next question will maybe be more for Professor Welzel and Professor DIRSCHKA. It's about the ex vivo module and what kind of equipment do you use for the ex vivo?
So we have two devices, the ex vivo confocal from Mavic and also the prototype of ex vivo line field confocal, which we got from DARMA for that study. And we also compared both. They are different because with the ex vivo confocal, you stain the tissue and you make a fluorescence imaging. And with line field confocal, it was like in vivo, completely native, the tissue. without any fixation and so on. But with the integration of AI, you can also use line field confocal without staining in an ex vivo mode, as Thomas DIRSCHKA have shown, because the technique is the same. If the tissue is in situ, so of course this is off-label, but you can do it.
Yeah, but I would be happy if I had the second
Yeah.
device as well, because I think it's very nice to have the information directly out at the surgical site and to discuss directly with the patient undergoing surgery and to limitate the time frame of surgery, because this will become a major issue in the future. We have all the baby boomers. I could stay in the operating room from morning 7 until 11 at night without interruption, because the demand is getting up. And for me, time makes a big difference. So these old Tübinger Torte technology, which is time consuming, to see the patient second time, to leave it open and then do it second or even a third surgical approach is for me not the future. The future must be very quick. Many patients will come and we have to deliver very subtle results to these patients in a very limited time frame.
Thank you very much. We have two more questions. One is from Andrea to all speakers. In your experience, which kind of lesion are more likely to give false positive results with AI? Some examples would be LPLK, etc.
I can take it. I mean, also based on my experience, also on the study, I would say that generally speaking, the main imitators can be squamous cell carcinoma and actinic keratosis, because sometimes there are hair follicles that can in a very momentaneous way, so only momentarily, give a false positive, but just at the time of a photogram. So you have to understand that making a diagnosis or in general using LC-OCT means that you need to do videos. You need to move on the lesion. Why? Because this dynamicity of the examination with LC-OCT makes very apparent criteria. Because when you move on a lesion, criteria such as a BCC lobule or an hair follicle or a hypersebaceous hyperplasia lobule, they come and go. So with this dynamism, they become much more apparent. And this is true for the human brain and also for the artificial brain, for the artificial intelligence. So and this score that you have with artificial intelligence, you might have noticed during the presentation that when we do videos, sometimes it changes. So it would go from 100%, then immediately after 99, then up to 100, then 90, then 100, because it is calculated photogram by photogram. So even if you can have in a moment, in a photogram, a doubt because you are exploring an actinic keratosis and you have a particular photogram in which an hair follicle can mimic a BCC lobule, then the immediately following photogram, you don't have this doubt anymore, and the score goes down immediately to 0 or to a very low score. So to answer this complicated question, the most dangerous, in quote, mimickers, so for the truth of artificial intelligence, in my opinion, are actinic keratosis, because especially in proliferative actinic keratosis, you can have a proliferation towards the dermis that might mimic superficial BCC, for example. But if you do a dynamic exploration, then you are able to overcome these doubts, and the artificial intelligence as well. For LPLK, so lichenoid keratosis, in my experience, it doesn't really represent that much of a mimicker, because you have a lichenoid band of the junction, not that many follicles. So I would say more actinic keratosis. I don't know if my colleagues agree with me.
So we still have had one melanoma mimicking superficial BCC, very thin melanoma, but So I always would recommend, like you have done, you should not look at a single image, but over the whole lesion. And if there are only very few blinking images with AI, then and the other images are negative, then this is quite safe. And also you have the dermoscopy and you know that this was a pigmented lesion. So always looking in the whole context of the question.
Completely
Then
agree.
it's rather safe. And there's also one question I see here with the AI assistant
Exactly. So I think we can
diagnosis
answer. I think
for
we can answer
lentigo
both.
maligna. Yeah,
Yeah,
so
both in one.
lentigo maligna, of course, it's also possible, and we use it. And we also use it if we make a non-surgical treatment of lentigo maligna with imiquimod, which is working very well. And then it doesn't make sense to make biopsies. And for that indication, it's really very nice. And I'm waiting for the AI also for melanocytic lesions, as you mentioned. And then, of course, you can also use it for lentigo maligna.
Yes, fully agreed by my side. I do not have anything to substantiate these ideas.
Yeah, thank you very much for the presentation. I'll share in. Okay, sorry. We'll share afterwards through a mail the link, a link to a forms that you can answer to give your opinion on this specific session, but also requests or more information for or new subjects for the next sessions. And I would like to thank you again, Professor WELZEL, Professor DIRSCHKA, and Professor SUPPA for your presence here and your invaluable advice for this presentation. I wish you all a very good evening, and we'll make sure to share the recording of the session right after. Thank you very much to all.
Thank you. Good evening.
And bye. Have a nice Christmas time.